spirometry, because this is the basis to diagnose COPD. But there are also pitfalls in that classification, which is necessary to do some additional testing, for example, lung volumes and hyperinflation, diffusion capacity, arterial blood gases. Also, we'll talk a little bit about imaging in COPD, chest X-rays, high-resolution CT scanning, and a short review of modalities to assess exercise capacity and prognostic indexes. And last, but also very important, but I will only address this briefly, the extrapulmonary manifestations and comorbidities of patients with COPD. First of all, the review of the physiology and anatomy. Why do we breathe? The respiration, in fact, is something that happens at the cellular level. In our muscle cells, we burn oxygen to create energy, and as a result, there's also the creation of carbon dioxide, which we need to get rid of. So for this continuous process of burning oxygen and energy creation, we need the blood circulating in our body to have this continuous supply, and that's why we have circulation. And the circulation is connected with a very clever ventilation system, which are the lungs. And the ventilation is a continuous supply of ambient air, which is nicely opposed to the circulation, and so we can extract oxygen from the ambient air into the blood, and we can get rid of our carbon dioxide. So that's mainly the function of the respiration system. So you might know that we have two lungs, a left one, a right one. And the left one exists of two lobes, an upper and a lower lobe, and the right one, three lobes. There's a small difference. And that's because at the left side, you might see the excavation over there. That's where our heart fits. That's why the lung at that side is a little bit smaller. The main bronchus is the trachea, and further it splits up in the bronchial tree. It splits up many times until we have microscopic airways, small airways, and they end up in a bunch of alveoli, as you can see there. And those alveoli are embedded in a capillary network, and that's why you can also you can see that we just discussed that this is where the blood is nicely communicated with the ambient air that is every time refreshed in the alveoli, and we can have the gas exchange. If you look at the airways, COPD is also mainly an airway disease, and we have a closer look. You see that the inner layer of the airway consists of epithelial cell, which is surrounded by connective tissue, and within that connective tissue there is airway smooth muscle embedded. And also we can find some goblet cells which produce the mucus. So there's some review of the anatomy if we talk about COPD. So let's take a case, which would be read file through the discussion, of a 68-year-old woman. She's a widow, former teacher, and she smoked 15 cigarettes a day, and she has 45 pack years. A pack year, we consider a pack year as smoking 20 cigarettes a day during 365 days a year. That's a pack year. And she has complaints of cough and dyspnea on exertion. And now the question is if that woman has COPD. So how should we assess this? And let's have a look at the definition of COPD. And it says that COPD is characterized by persistent airflow limitation. That's the main characteristic. It's very important. And that persistent airflow limitation is the consequence of an inflammatory process in the airways and in the lungs. And the inflammatory process is the result of the continuous exposure to noxious substances, and that's mostly cigarette smoke. It might be some exposure from occupation settings, but mostly that's cigarette smoke. It's a disease that is most of the times progressive. It's common. It's preventable. If you don't smoke, you don't get it, and it's treatable. And treatable means that we can do something about the symptoms, but we can't cure it. It's a chronic disease. And new from the 2011 definition is also that there's an extra sentence in the definition, and exacerbations and comorbidities contribute to the overall severity in individual patients. We will discuss it later on, but it's a very important part of the definition of COPD. So let's have a closer look to that airflow limitation. How does that come? How does a patient with COPD, that inflammatory process, how does that result in airflow limitation? If we look at the airways, that chronic inflammatory process means an inflammation of the bronchial wall, which gives, because of the inflammation, thickening of the wall, but also results in a small airway remodeling and obstruction of the airways. Also because the globular cells will secrete more mucus. That's one part, and it's very easy to realize that if there is an obstruction, narrowing of the airways, that this will result in airflow limitation. But the other part is at the lungs. The inflammatory process in the alveoli results in the destruction of alveoli, and that results in the loss of the normal elasticity of the lungs. And you can imagine that the airways hang up within the lungs, and the elasticity of the lungs keep those airways open. If there's loss of elasticity, if there's destruction of the lungs, then there's a more easy collapse of that small airways, and this contributes importantly to airflow limitation. So these are the main figures of how a patient with COPD develops that airflow limitation. From a clinical perspective, the inflammation of the airways is mostly described as chronic bronchitis, and the destruction of the alveoli is mostly described as emphysema. Now, within one patient with COPD, it can differ markedly. A patient can suffer more from chronic bronchitis and less from emphysema, and another one can suffer more from emphysema and not even have any symptom of chronic bronchitis. It's also important to realize. If we now want to establish the diagnosis, then we certainly need spirometry. If we have patients with symptoms of shortness of breath, chronic cough, sputum production, and he has an important exposure history, mostly again tobacco smoking, then, and if we suspect diagnosis of COPD, then we have to perform spirometry to diagnose the disease. And a spirometry is in fact a very easy investigation. The patient breathes in a closed system, and we ask them to do a maximal inspiration, and after maximal inspiration to breathe out as fast as possible. So to do a forced expiration, and a forced expiration till he can't breathe out anymore. So it's a maximal expiration. So that is the spirometry maneuver, and that's all we need to have the diagnosis of airflow limitation. If we now have a look at the curve, the volume time curve of a spirometry, then we see in black the curve of a healthy person, and here in orange the dotted line, the curve of a COPD patient. And if we now have a look at the marked lines there, then we see that for to exhale a certain volume, it takes much longer for a patient with COPD to exhale than for a person with normal lungs. If we have a look at a certain time over here, then we see that at when a normal subject, a subject with normal lungs, has exhaled completely, that there's still a lot of air in the lungs of a patient with airflow limitation, and it takes much longer to exhale or expire completely. Okay? So this is a volume time curve. If we follow the guidelines, then it says that airflow limitation, COPD, is defined by a ratio of the FEV1 and the FVC below 0.7. FEV1, that's the forced expiratory volume in the first second, and FVC is the forced vital capacity. So the vital capacity is the amount, the volume of air that one can expire after a complete inspiration, and the FEV1 is the volume that one can expire in the first second. So here I have on the time axis, on the x-axis, I have marked 1 second, and you can see that in a healthy person, then almost all of the air that I hope you and I are both healthy, that we can expire almost all of the air in our lungs in the first second. And that's not true in patients with COPD. See that in the first second, there's here in this patient maybe around 30–40% he can exhale in the first second. But the forced vital capacity will eventually be almost equal to that of a normal subject. So if you divide the FEV1 by the FVC, then we have the ratio, and if it's below 0.7, then we have diagnosis. Is that clear? Yeah. And as you can see here as well, that the lower the FEV1 is, the more severe the airflow limitation. So, and that's how the GOLD guidelines have assessed their grades of severity. So we have the needed diagnosis, so that's the ratio, and then afterwards we can split up for stages of severity. And if you want more than 80%, then stage 1, it's mild disease, is between 50 and 80% predicted, then it's moderate disease, below 50% is severe disease, and below 30% is very severe disease. Also there, if the FEV1 is below 50%, but there's signs of respiratory failure and blood gases, which I'll explain in a minute, then we have also very severe COPD. And this is the most, so the volume time curve is very easy to interpret and to explain what COPD is, but this is the most used curve in clinical practice. And this is a flow volume curve. And on the x-axis you have volume, liter, and on the y-axis you have the flow, the amount of liters in a second that is expired. And what you can appreciate compared to the predictive curve is that there's a clearly lower peak flow, so it's also demonstrated the airflow limitation, and also if we go further on the volume curve, we have a typically scooped out flow volume curve. If you see this in a flow volume curve, it is almost diagnostic for COPD. So you can see in one blink of an eye that there is airflow limitation. So if we go back to our patient now, we did some spirometry, and she has an FEV1 of 0.5 liter, half a liter, and which is 34% predicted, and she has an FEV1 FVC ratio of 0.4. So does she have COPD, and what stage? Who paid attention? Any idea? Stage 3, okay. She has stage 3 COPD. So if are we ready now? Do we know that she has COPD? Do we have to diagnose something else? And there's a lot of information that we don't know. We know that she has COPD, but we don't know, we have not assessed how much symptoms she has, and we have also not assessed how many exacerbations she suffers from. Now, let's first explain to you what an exacerbation is. And a chronic disease like COPD, which is a chronic low-grade inflammatory disease, inflammation of the bronchial wall and the lungs, like I explained, a sudden deterioration of that disease can happen. And I always explain that to the patient like it's a flare-up of the low-grade inflammation. And that's also the easiest way to interpret it. The definition of such an exacerbation is a worsening of the patient's condition from the stable state that is beyond the day-to-day variation in symptoms. It's acute, and it needs some extra management from the doctor, some change in medication. That's the definition of an exacerbation. The symptoms: increased dyspnea, increased cough, sputum, and there's an important clinical consequences: hospitalization, lung function decline, increased mortality, deconditioning, and mostly those patients, if they suffer from exacerbation and they come out worse than before, then they are prone to suffer from more exacerbations. So exacerbations are one of the most important issues in patients with COPD. And in the last update of the GOLD guidelines, they say that we no longer only have to assess the airflow limitation with spirometry, but also we have to assess the symptoms and those exacerbations. And therefore, they came up with a new classification system, and it's the ABCD quadrant, and I go through it with you. First of all, we have to assess the symptoms, and that's shown here. We have two classification systems in COPD to address those systems. One is the modified MRC dyspnea scale, which is this one. It's just a great classification to grade the dyspnea. A score of 0 is I only get breathless with strenuous exercise, and grade 4 is I'm too breathless to leave the house, or even I can't change clothes without being breathless. So, and in between there's some other classifications. You also can use the CAT score. And CAT score stands for COPD Assessment Test. That's a new score, and it's even more appropriate. Then, next to the symptoms, we have the severity of airflow limitation, like I just explained you. So it stays in the new classification system with stage 1, 2, 3, and 4. And third, we have the risk of exacerbations. And the exacerbations is very easy to calculate. You just ask the patient, how many exacerbations did you suffer from in the last year? If he says more than 2, then you have a higher risk. You can grade the patient. So, and this way we have a broader assessment of the patient with COPD, and you can assess in a broader way the risk of the patient, the severity of the patient's disease. If we go back to our patient now, she has dyspnea, and we graded this at the modified MRC grade 2, and she had 2 exacerbations in the past 12 months. And she still had a stage 3 airflow limitation. So where should we put her? Okay, very good, very easy. It has to be easy, because otherwise doctors don't use it. So it's a stage 3D COPD. So we know a little bit more. Now with the D, we know that she's at high risk. She suffers from exacerbation or has a more severe airflow limitation and has more symptoms. But there's still a lot of information that we don't know about that patient of COPD, which is very important. Does she has emphysema, and how much emphysema? As I told you in the beginning, that the patient can have more or less emphysema, more chronic bronchitis, less emphysema. Does she has hyperinflation? I'll explain in a minute what that is. What is her diffusion capacity? Does she need oxygen? what's her exercise performance? Can we tell something about the prognosis? There's a lot of information that we still don't know. And luckily we have some other diagnostic modalities to assess that. This is just X-ray from a normal person. I think it's good for you not only to see the investigations of a diseased person, but this is a normal one. And what we can see is that there's a normal position and size of the mediastinum. This is the aortic notch and the wall of the descending aorta, which is normal. The normal positioning and size of the heart. And you might remember, if you reviewed the anatomy, that the heart is on the more on the left side. This is the left side because we look at the patient's left side. This normal size and positioning of the heart, we see the left and the right diaphragm here below, which is also normal positioned. The costodiaphragmatic signi on both sides are open. I don't see any fluid, no pleural changes, and the lucency and the imaging of the lungs itself, lung parenchyma, is clear. I don't see any infiltrations or consolidations. This is a normal chest X-ray. Okay, and this is a chest X-ray of a patient with emphysema, and I describe a little bit what is changed. We see that there's a low set diaphragms. See that there are, if you compare it with the previous, that these diaphragms are lower and more flattened. You also see that the lung parenchyma is more loosened. It's harder. It's more black than on the previous slide. So that means that there might be some destruction of lung tissue. And what also shows that is that you can see maybe some holes in the lung parenchyma over here. And here you see clearly that the wall of such a bulla or bleb, and that's consistent with emphysema. But we don't use that much normal chest X-rays for diagnosing or imaging emphysema, because CT scans of the lungs, the high resolution CT scan as we use it in clinic, is much more easy and gives much more beautiful images. And as you can appreciate in a patient with emphysema, that there is a large destruction of the lung parenchyma. See that there are different holes that just fall into the lung, and which is the picture of a patient with COPD. It looks really like this. This is no exception. And which is not clinical practice, but I believe this is very beautiful images. For me as a chest physician, I like it very much. It's an electronic microscopic view of the alveoli in patients, in a normal patient and patient with emphysema. And you can clearly see what happens because of the continuous noxious substances, continuous cigarette smoke, the inflammatory process. There really is an attack on the alveoli, and they have really destructed. Another thing we can see on HRCT scan, high resolution CT scan, is bronchiectasis. And bronchiectasis are you see again here holes in the lung parenchyma, but these are in the lungs, but these are not in the lung parenchyma, but these are abnormal dilated airways, pathologic airways. And this is mostly the results of recurrent infections. And it's a process of destruction and repair. And airways of patients with COPD, the airways are inflamed, and also the ciliary transport and the cough reflex is abnormal. And that means that patients with COPD are more prone for respiratory infections, and when they have repeatedly those infections, then bronchiectasis can happen. And this happens in around 20% of patients with COPD. And also the ideal way to diagnose those bronchiectasis is to HRCT scan. Now, we talked about spirometry, and but spirometry fails to assess all the lung volumes. If you have a complete expiration and there's no then there's always some air left in the lung. And with normal spirometry, there's no way to diagnose that. So, and after complete inspiration, expiration, there is some air left in the lung here, and that we call the residual volume. If we are normally breathing, these are tidal volumes, and you're normally breathing like you're doing now, and then after a normal exhalation, the air that is left in the lung is the functional residual capacity. And that's a very important term because at that moment, if you have a normal exhalation, you can try it yourself. If you breathe in and then you just relax, then you go to your functional residual capacity. That's where your chest wall and your lung is in rest. That's the retraction process of the chest wall and the lung are equal or at rest. So, but how can we now assess those residual volume and functional residual capacity? Therefore, we have the body plethysmography. Because it's a difficult word, we say body box. That's more easy. And it's based on the ideal gas law of Boyle, which says that maybe you remember that. Certainly, you as a biomedical science students. It's that pressure and volume for a given gas is a constant. So we place the patient in a box. They often don't like that, and we put them in the box, and they breathe in the system over there, and they breathe against the closed valve. And we measure the pressure differences at the valve, and also the small pressure differences when he does the breathing maneuver in the box. And so we can calculate based on those pressure differences what the volume in the lung of the patient, what the functional residual capacity is in that patient. And with using normal spirometry, we can also calculate the residual volume. Okay? If I go back, I can show you. If you know what the functional residual capacity is of a patient, and we do some spirometry, then can we just extract the expiratory reserve volume, and we know what the residual volume is. Okay, you understand completely, I know. But why is the functional residual capacity, why do we want to know in a patient with COPD what the air left in the lung, how much it is? Is that important? And yes, and I'll explain you, I try to explain you, it's a little bit difficult. This is a volume pressure curve, and it shows the changes in pressure when there is a change in volume when we breathe. Here, at functional residual capacity, what is it again? If we breathe normally and we let everything go at the end of a normal expiration, and everything is in balance, when we have equal retraction from the chest wall and equal retraction of the lung, then the pressure is 0, and that's where we have our functional residual capacity on that volume. Okay, so when we breathe in, this is the compliance curve of the chest wall, and this is the compliance curve of the lung. And when we breathe in, then we can, this is the complete system, the balanced system of the chest wall and the lung. When we breathe in, we see that we can't breathe in more than total lung capacity because the pressure in the lung is too high. The lung wants to be smaller if we breathe in. If we breathe out to residual volume, where am I? Yeah. If you breathe into residual volume, then the chest wall is the limiting factor because the chest wall wants to be bigger. Okay? So, in a patient with emphysema, then I told you already that there's loss of the normal elasticity of the lung. So I showed you the destruction of the alveoli. So the normal structure of the lung loses the normal elasticity. The lung doesn't want to be that smaller again. So we see that the compliance curve goes that way. There is less change in pressure when there is an increase in volume. And if you look at that figure, that means that the balance between the chest wall, which doesn't change, and the lung compliance, that it goes up, and it looks like this. We see that the functional residual capacity in patient emphysema goes up. He breathes at a higher volume because the lung doesn't pull that hard anymore at the chest wall. Okay? And why is that important? Does everybody understands this figure? A little bit. Once again? Yeah? Okay. What we look at is compliance curves of the chest wall, the lung, and the system. Let's just forget the figure, and I try to explain it like this. If we breathe in, let's say, you know what a pneumothorax is? Pneumothorax, that's when your lung, when you have, for example, a hole in your chest, and there comes air into your chest, and then the lung is communicating, or the pleural cavity is communicating with outside. What then happens is that the lung collapses completely to a fist, because the lung, she always wants to be smaller. There's some elasticity. So, but if we have a normal functioning system, then our lung and the chest wall are one system, and the one pulls to the other to make an equilibrium. Okay? So if you breathe in, then the lung becomes bigger, and just like normal elasticity, she wants to be smaller. If you breathe out, then the chest cavity wants to be great, wants to be bigger. So they fight with each other. If the lung is diseased and loses its normal elasticity, then it doesn't pull that hard at the chest wall. Yeah? And what then happens is that that the equilibrium, the balance, goes to a higher lung volume. So we breathe at a higher lung volume, and that's what we see there. And what happens then is that during years, when emphysema develops, when COPD develops, at the normal breathing, if this is the residual volume, this is the functional residual capacity, the air that is left in the lung when we are normally breathing, that it goes up because of a lot of elasticity of the lung. And when that happens, that is not that good for a patient with COPD, because he is breathing at a non-favorable part of the compliance curve. He has a higher work of breathing. And secondly, there's inspiratory muscle weakness due to the hyperinflation. I showed you already that chest X-ray with the low set diaphragms. They are flattened diaphragms. And when that happens, that's a not optimal position, a not optimal strength, length position for the function of the diaphragm. So these are important issues that contribute to the dyspnea, to the breathing problems of a patient with COPD. Okay. Another factor we really like to know in patients with COPD is the diffusion capacity. And the diffusion capacity is nothing more than the capacity of the lung to extract oxygen out of the ambient air. And we have the red blood cells who are in the blood, in the capillaries, and in the red blood cells there's hemoglobin, and that hemoglobin has a very high affinity for oxygen. So when a red blood cell travels to the capillary around the alveolus, like you see there, it extracts and binds all the oxygen out of the ambient air. But when an alveolus is diseased, this might be not that easy, and this might give some problems. And as we can see here in this figure, we see if the alveoli are normally functioning, that the saturation of the blood, of the blood goes very easy and very fast. If an alveolus is dysfunctional, then you see that the blood needs more time to be saturated. And this might not be a problem in rust because the time that the red blood cell is in that capillary might be enough But when you do some exercise, then you have a higher cardiac output, and then the time that the red blood cells are in the capillary might be shorter, and then you can see that for normal alveoli there's no problem, but for dysfunctional alveoli the saturation time is too short, and that gives important problems. That diffusion capacity we measure with carbon monoxide. That's also a test we can do in the lung function laboratory, and the patient does complete exhalation, and then he inhales a single breath with a mixture of gas containing helium and carbon monoxide. Then we collect the exhaled air of the patient, and by measuring the content of helium and carbon monoxide and the other gases, so we can calculate what the diffusion of the carbon monoxide is. We use carbon monoxide because it's a 100% diffusion. It's a very small molecule and has a very high affinity for hemoglobin, and you might know that carbon monoxide is dangerous because when it's in ambient air and in the room, then it binds completely to hemoglobin and patients can die from it. But we use it in very small, just single breath concentrations, and that's a safe method and an excellent method to assess that diffusion capacity. The way we diagnose respiratory insufficiency, which is the lack of oxygen and the excess of carbon dioxide, is with a direct measurement in the blood, and that's an arterial blood gas. We know that we have arterial blood and venous blood. Venous blood comes from the body, from the muscles, and goes to the lungs, and the arterial blood is oxygenated and goes from the lungs to the system to provide. So from that arterial blood has to be saturated with oxygen and has to have very low concentration of carbon dioxide. Here are the normal values of the partial pressures of O2 and the partial pressure of CO2. And when a patient has advanced COPD and develops chronic respiratory failure, we can diagnose that in the blood, and we see that there's a low content of oxygen, below 8, and a high content of carbon dioxide. This is also very important to assess in patients with COPD because when a patient is hypoxic, we can give him some oxygen. And giving oxygen to a patient who needs it, as you can see in this figure, this decreases survival. Patients that are still alive after this time in months, you see that those who get oxygen have a much better survival than those who don't. So we have to assess the arterial blood gases, the amount of oxygen in the blood, because with a simple intervention like giving oxygen, we can improve survival. Another thing which we use this arterial blood gases for, we do it here in the radial artery. You can feel it yourself. And if you feel the pulses, then you have to feel where it is, and then just try to hit it, and then you have blood. But another important issue, when a patient, for example, suffers from an exacerbation, and he can have acute respiratory failure. If there's, due to an exacerbation, there doesn't blow any wind through the alveoli, then we can see that there's a rapid increase in CO2 in the blood. And CO2 is an acid, because normally, like you and me, like breathing, and we're very comfortable, I hope so, then we have complete homeostasis. Our pH is 7.4, and it is regulated due to this system. The CO2 we regulate in the lung, and this is an acid, and the bicarbonate, which is a base, we regulate in the kidneys. And this is completely balanced in our body. If we now have patients with COPD who develops an exacerbation of COPD and acute respiratory failure, then we see an immediate increase in CO2, which is an acid. There's more acid, and the patient gets acidotic. And this is really life-threatening. Acidosis, respiratory acidosis, results very fast in coma and death. And the patient is admitted to the ward with an acute respiratory failure, acute elevation of CO2. There you have the answer. Then what we usually do is help the patient breathe, and therefore we use some positive pressure ventilation. We put a mask, a full face mask, on the patient, and when he breathes in, the machine triggers that he has an inspiration and gives positive pressure, and this results in that some wind blows through the alveoli, and that some of the CO2 is extracted and extra oxygen is given. And this can be life-saving. So, okay, this is very short, but it's an arterial blood, assessment of arterial blood is a very important diagnostic modality in COPD. So back to the case, we have assessed some more details. We already knows how much she smokes, what her dyspnea score is, how much exacerbations she has. We know what her spirometry is. She has a stage 3 COPD, and now we know that her residual volume is 220% of predicted. FRC, functional residual capacity, is 180% of predicted. Diffusion capacity is only 35% of predicted, and she has chronic respiratory failure with a PCO2 of 6.8 and a PO2 of 7.2. This is chronic because the pH is near 7.4, and the kidneys had the time to correct with bicarbonate for this elevated CO2 acid-base balance, you remember? So if it would be acute, then this CO2 goes up and this pH goes down because the kidneys don't have the time to correct. Okay? We performed a CT scan and she had centrilobular emphysema. So, we have patients with gold stage 3 airflow limitation, risk classification D, centrilobular emphysema, no bronchiectasis, severely impaired diffusion capacity, hyperinflation, and respiratory insufficiency. Are we happy now? Are we ready? Or do we need to assess something more? What are her extrapulmonary manifestations? What is her cardiovascular status? Does she have osteoporosis? Does she suffer from anxiety, depression? Does she has other comorbidities? As you might remember, the first definition I showed you, that some extrapulmonary effects and important comorbidities may contribute importantly to the disease severity in the individual patient. And this is not really part of the definition of COPD. And in the guidelines, it is also stated that you have to assess and look for those comorbidities. Low body weight in COPD and advanced COPD, involuntary weight loss is very common. In severe COPD, almost 37% of patients really have involuntary weight loss and underweight. And body mass index of lower than 21 is also considered a very important prognostic factor in patients with COPD. Exercise testing is another issue, and we normally have two tests. We have a 6 minutes walking distance, which is a very easy test. You walk with the patient, you say start, you walk 6 minutes, you say walk as fast as possible, and after 6 minutes you measure how many meters he has walked. That's a standardized, very easy, and also prognostic very important. The distance a patient can walk is prognostic for his survival. Another test we can perform is a CPET. What's now CPET? It's a CWRT. It's a continuous work rate test, and CPET stands for cardiopulmonary exercise testing. So, and that means that we put the patient on a bike, and we ask him to perform the maximal exercise, and the load he has to carry, the load he has to cycle, increases every minute. So it's a hill that goes steeper every minute, and no one, everybody has to stop. That's a very good way to assess the exercise capacity of a patient. But those two tests are very good to assess the exercise capacity of a patient, and are also prognostic tests. And this index is very popular in COPD. It's called the BOAT index, and it includes the BMI that I just mentioned. That a low BMI, lower than 21, is prognostic important, is included in that index. The obstruction, the O stands for obstruction. There's a lower FEV1. The lower the FEV1, the more points you get in that score. Also the dyspnea, which we already mentioned, also in the risk classification, is used here, and the exercise capacity is also included using the 6 minutes walking distance. And this is the study mentioned. You see the lower the score, the higher the survival is. So these indexes are also very very much used in COPD. So COPD is a very complex disease. It's more than airflow limitation. It consists of airflow limitation, dyspnea, quality of life, oxygen, CO2, exercise tolerance, body mass index, and so on. And those comorbidities, like I said, are very important to assess. This is literally what stands in the COPD GOLD guidelines. Patients with COPD are at increased risk for cardiovascular disease, osteoporosis, respiratory infection, anxiety and depression, diabetes, and lung cancer. So for all these comorbidities, it's very important to look at it routinely and to treat it appropriately. Just to give this example, only a minority of patients with COPD die from COPD. In patients with severe COPD, mostly die from respiratory causes. But look at those with milder COPD. All those patients die from lung cancer, cardiac failure, or other diseases. So this is something important to know. And here you see the cumulative events, cardiovascular events in patients with COPD compared to healthy controls. And you might say, yeah, patients with COPD that have smoked, but this is matched for smoking status. So these are patients who don't have COPD but have smoked the equal amount of cigarettes. So COPD is a major cardiovascular risk factor. So we are now turning from COPD as a respiratory disease into COPD as a complex syndrome. That's what nowadays is a lot of investigation, a lot of research is going on. That COPD is just a part of a greater syndrome, which includes also ischemic heart disease, cardiac failure, diabetes, metabolic syndrome, osteoporosis, and so on and so on. So the multi-component pathology in COPD has also to be assessed, and for all these issues there are different diagnostic modalities, which I will not tire you. With osteoporosis, with DEXA scan, muscle dysfunction, also with DEXA scan of bioimpedance. We talked about exercise intolerance. We have some interviews for assessing the mental state. We talked about spirometry for airflow limitation. We talked about hyperinflation, but also the cardiovascular assessment and it has to be done in a patient with COPD. If we now go back to our case, we had our patient and we diagnosed her with a stage 3 COPD, and when we end up after we have done all the diagnostics, we have this patient who has also an impaired exercise capacity, low body weight, a BOAT index compatible with a mean survival of 4 years, a DEXA scan showing osteoporosis, hypertension, signs of right heart hypertrophy on the ECG, signs of ischemia during the cardiopulmonary exercise testing, and we refer for a cardiovascular checkup. So, in conclusion, instead of saying that a patient has COPD, we can say she has a COPD with severe airflow limitation, with a high risk of exacerbations, central globular emphysema, severely impaired diffusion capacity, hyperinflation, respiratory insufficiency, pulmonary cachexia, osteoporosis, hypertension, right heart hypertrophy, and suspected coronary insufficiency. That's what we call diagnosis. So we have to characterize all the patients with COPD because every patient is also different. Just like you can say, I have a car, you can also say what kind of fancy car you have and define all the characteristics. We have to do just the same with patients with COPD and end up with all different colors of COPD. So, in summary, that's the last slide. Lucky you. The diagnosis of COPD should be considered in symptomatic patients who are exposed to noxious substances, and to diagnose, we need to assess airflow limitation, and it has to be confirmed with spirometry. And the new international guidelines, as I showed you, do not only include that airflow limitation, but do also assess symptoms and exacerbation frequency. And to further characterize those patients, additional testing is necessary. And this includes the static lung volumia, so the hyperinflation, diffusion capacity, HRCT scanning, exercise testing, assessment of body composition, bone mineral density, and so on. And although it's a respiratory disease, nowadays it's considered a complex, multi-organ, multi-component syndrome with important and extrapulmonary manifestations and comorbidities. And this requires a holistic approach towards diagnosis and management. So, that's it. Do you have any questions? No questions.